We will talk. It's like more like a chit chat than a classical presentation. We will be talking about presbyopia correction in general, not only the premium IOLs, the trifocals, and so on. If you could be kind enough to please raise your hands if you are doing more than 25%, if you are offering more than 25% of your patient of any kind of presbyopia correction. Would you please raise your hands? More than 25% of the cataract surgery, you are offering any sort of presbyopia correction. Very few of us. Thank you. And you think those people who are seeking for glasses independence, especially for the near, are less than 25% of your patients? They are actually much more, right? So, my simple answer is you offer presbyopia correction for everyone who's interested and fit. Very simple, direct question. By direct answer, actually. By everyone, that depends on you. See, we as doctors, we sometimes get judgmental, and we offer people that we think they will love the trifocal. They are eligible for that fancy of correction, of presbyopia correction. Maybe humble-looking, simple people, we do not offer them, or maybe, well, from my limited experience, and I'm confident now talking about the topic. 5 years back, I wouldn't dare to. But today, actually, I mentioned presbyopia correction in the broad spectrum to everybody, even those who are unfit. And I say, see, there are these kinds of IOLs and techniques that actually, unfortunately, unfit for you. So later on, when the patient comes back or even he hears about the topic from somewhere else, he wouldn't blame me. And I got blamed. I think most of you got blamed for not putting certain IOLs in certain situations for certain patients in the old days. And not to be blamed, this is one thing. And the other thing, I'm aiming at marketing this part of practice. I'm aiming at elevating the knowledge and the social knowledge about these techniques and IOLs. So as a doctor, I offer them to everybody. I'm not saying everybody in general. I'm not over marketing them, but I mentioned the topic to everybody, even those who are not eligible for them. And who is interested? See, when you ask anybody, you only want to be glasses free? Is yeah, of course I will. But what I mean by interested, the ones who are really interested, that are dedicated and ready to sacrifice some of their night clear vision, they are ready to accept some photic phenomena, and those people who are patients who will wait for their brain to get adapted to the new vision that they're gonna get after the surgery. Those are the interested people from my point of view, and fit. And we will talk about those people later on. So. Before we go into who those patients are to offer them the techniques, I would like to go skimming over the techniques that would help in presbyopia. Presbyopia, in the old days, monofocal. If you had a little bit of wither astigmatism minus myopic astigmatism, you'll be happy. Some sort of near vision will be kept. And to go further, enhanced monofocal, these IOLs would give some intermediate vision that is helpful. In combination with monovision, I must say I'm not a big fan of monovision. They talk sometimes about micro monovision and so on. Yet these are very well known techniques and widely used. I'm not quite experienced in them. Sometimes I get people when you have some like minus 0.75 error in the biometry, and they said, doctor, I see very well in this eye, but not in this eye. I don't like it. I say, but for near, this is good. She says, yeah, I see it, but I don't like it. That's why I'm not quite doing monovision, but it is there. The other, if you go further, we have the EDOF, extended depth of focus IOLs, and I think maybe Dr. Hasni sometime back he mentioned that. I think this is the future here, enhanced monovision and EDOFs. I think I'm not quite into the industry. I'm not a consultant to any company. I have no financial interest of any of these. But EDOF are evolving, and they provide a good amount of intermediate vision without the hassle of the trifocal, the photic phenomena of trifocals. Then we have the sector monofocal, multifocals, and trifocal. Trifocals that they meant to be glasses free in all distances, but of course with cost. The doctor and patient should know these facts. The glasses independence is not. If we go from left to right, we're gonna be more and more glasses independent. But again, as Dr. Hasni said, we never promise our patients a total glasses free, and we never forget that our biometries do have errors still, and we still have 1 to 3% of our patients will get up to one diopter of error, and this should be kept in mind. The refractive error in these kind of IOLs is much more annoying. The photic phenomena, from left to right, we are going to get more and more. Contrast sensitivity, and this should be kept in mind again in certain cases, like in glaucoma or certain medications that would decrease the contrast sensitivity in some corneas disorders and diseases. And of course, lastly, the cost. The cost is an issue. Now, who are fit? Who are the patients who are fit for those kind of techniques and IOLs? Well, we have considerations, personal consideration, needs, carriers. We wouldn't offer these kind of trifocal lenses for a driver, a night driver. Lifestyle, what does he want? You need to understand what does your patient wants actually. Is he an engineer? Is he a writer? What does he do most? Does he read books? Does he work on the PC all the time? What distance he really interested in more, so that you can tailor your decision according. Expectations. This one part that I really find not hard to let us, not that I wouldn't use manipulate, but to deal with, because most people will be will understand the common sense. Will understand when you don't get 100% the perfect result. You can accept 90%, 85%. In exchange, and on the other hand, you're gonna get 50% of the solution, and your patient should really understand what the consequences that he's gonna face, what kind of photic phenomena he's gonna face. He should understand that there is a period of brain adaptation, and he should be willing to do so. General health, chronic illnesses, medications, as we mentioned, some of them might affect contrast sensitivity. Age, well, a patient in his 85, and you're not quite sure about the macula is not quite good. I don't think it's a good idea to go for higher and higher correction for the near vision. Ocular, healthy cornea and macula, this is the classical for the multifocals. Severe dry eye can be treated. Glaucoma, contrast sensitivity, exfoliation, and the stability of the lenses. Hyperopia, Dr. Hasni covered that. The hyperopic patients are the perfect, of course, individuals, even for those who want to start doing these kind of cases. Maybe in the myopic part, not high myopia, the low dioptric power myopia, 2, 3, 4, 5 maybe. You can go for sector multifocal rather than trifocal, or EDOF maybe. Previous laser vision correction, RKs, I don't think so, but laser vision correction with pretty regular cornea you can go for the trifocals, sector multifocals, EDOFs. Astigmatism should be treated, of course, and you can never a patient with like trifocal can never handle vision with more than 0.75 maximum of astigmatism. Pupil decentration, angle kappa, Dr. Hasni covered that as well. It's not a big problem for the newer generations of the premium IOLs. They are quite forgiving. And to reach here, the perfect, near, intermediate, and distance, we're not there yet, but I think we are on the track. And thank you very much.